Good afternoon. Can everyone hear me?
Oh, you do, so you pay a fee.
Can you hear me back there, Patty?
Yes.
My name is I'm Jay Finley. I'm an endocrinologist from the Medical College of Wisconsin, and as many of you know, I've been coming up here about 5 times the past 6 years. I don't even know how long it's been now. Quite a while. And I want to start by just saying thank you for inviting me to give this presentation, but more importantly, thank you for all the support that you have provided me and my associates, my staff, during our time here in the past 6 years. We've really enjoyed coming up here. I've been very impressed with the quality of the care, and I hope we've been able to give you some feedback and some help with some of your more challenging patients with endocrine disorders and diabetes. The topic that I was asked to talk about today is the adrenal nodule. Which is something, of course, which is a segue to many of the things I was interested in. And I titled this the Not-so-Incidental Adrenal Nodule. About 5 years ago, Danielle Orfrey, who writes for she's on the staff at NYU in Bellevue, New York. She writes in our column for the New York Times, frequently writes things, and she was writing something about incidental findings in radiographs. And she just happened to mention the incidental adrenal nodule. She said, "Oh, what am I going to do with this?" So I sent her an email back, told her, "This is what I think you should do with it. This is why this was important and shouldn't be ignored." And we had a little back and forth, and I said, "Well, I'm going to New York to give a talk about this in February. You should come to my talk." Well, it was before the hurricane had come through, and Bellevue had been closed for a while, so I came and she gave me a tour of Bellevue, and we had a nice talk about adrenal nodule. So that was right. So I tried to influence the New York Times about this. I don't know how much help if I was very successful, but hopefully I'll be successful this afternoon. I do have some disclosures. Most of this has to do with some of my investigation at the Medical College on Cushing's. So first of all, this is a common problem. I mean, I think any of you who get reports from radiology and do CT scans of the abdomen in patients for a variety of reasons find that at least 4% of patients probably have nodular adrenal disease. And this frequency certainly increases with age, and older adults are probably as high as 7%. And in contrast to most things in life, they're equally prevalent in males and females. And there are many things that can cause these, but the important thing, and the point I'm going to make over and over again, is about 20 to 40% of them are associated with hormone excess. So a fairly high percentage, most of them are cortisol-producing adenomas. And we're going to talk a lot about most of the things on the left side. But many of them do not associate with hormone excess. Most of those are non-secreting adenomas, but there are things like neuroblastomas, ganglioneuromas, angiomas. And metastatic, if you're an oncologist, obviously that's one of the things we see a lot of. But rarely does an incidental adrenal nodule, the first time it's been found on imaging, represent the first metastatic region of the adrenal gland as the initial presenting feature of a malignancy. That is extremely, extremely unusual. In fact, Andy Anderson did a study a number of years ago, and it was like 0.3% or maybe and cysts and other things. So most of these are adenomas. And this just shows you that if you look at all of them, about 86% are adenomas, and most of which are benign. Obviously, adrenal cortical carcinoma is a small percentage of that. And again, as I said, 20 to 40% of them function. So by definition, this is something that was not anticipated on a CT scan of the abdomen for whatever reason. So incidental adrenal adenoma or nodule. Strictly speaking, the patients often don't have any symptoms, at least that have been previously discovered related to adrenal malfunction. And symptoms can be caused either by hormone excess, often unrecognized, we'll get to that in a minute, and the lack of business is really in the eye of the beholder. And large, very large nodules, fortunately, are uncommon, and of course, most of them, as you'll see in a minute, are. The adrenal glands, of course, are easily identified in most patients, especially in the United States, because they're surrounded by fat in the abdomen, and there's lots of people with lots of fat, so we usually have no trouble finding these. And I don't think the limb of the adrenal glands, these are two normal adrenal glands, are about the width of the diagram. So that's about a good way to sort of gauge this in terms of finding. And the one on the right side is sort of like an upside down V, and the one on the left is sort of upside down Y. Obviously, there's lots of variation in normals. But, you know, you can see that here's a normal adrenal gland on the left and a pretty obvious nodule. And here it's not exactly where it should be, but they right up in there. So it's pretty obvious that these, and even the one on the left, you can see the limbs of those adrenal glands are maybe a little bit bigger than the diagram. They might be a little bit enlarged. And here's a large left adrenal nodule, you can see it's 4 or 5 centimeters in diameter. So the adrenal glands are ideally seen on CT. In fact, much better than MR. When anybody tells you you should get an MRI of the adrenal glands, look at that with a great deal of skepticism. I mean, for the $3,000 it's going to cost you to get an MRI, you're much better getting a CT. Radiation aside, you get that much better resolution with CT than MRI. So I'm not even going to talk about MRI of these. So what are the concerns when you see adrenal nodule? Obviously, the patient, when they find out about it, when they look at their record, or you tell them about it, they're concerned about malignancy. And almost always you can reassure them that that's not the case. But one of the things they're not concerned about that you should be concerned about is whether there's dysfunction of adrenal function, particularly hyperfunction of adrenal. And again, as I said before, phenylchromocytomas make up about 3% of these, 1 to 2% secrete aldosterone, and about 20 to 40% secrete cortisol in excess. So how do we know it's not malignant? Well, it's really just based on imaging and size. For example, this is just a breakdown of various things, and the light blue is adenomas, which of course if you're 2 to 4 centimeters or less, the vast majority of them, and as you can see in yellow, very, very few, probably even less than that, are carcinoma. But once you get a lesion at 6 centimeters or greater, the number of percent that's carcinoma goes way up. So big lesions certainly need careful scrutiny. So the other thing is that, and that's what this is. So 25% of nodules greater than 6 centimeters are malignant. The shapes and borders, and I'm surprised that regular invasive borders highlight the malignancy. But the key thing is density. So lesions that contain a lot of fat, that is, have a low household unit, say 10 units or less, are always benign. I mean, always benign. So if you have a 2.8 centimeter adrenal nodule, it's got a household unit of 7, you can reassure the patient without any concerns that that's benign. Sorry, I spelled out Dr. Hounsfield there, it doesn't have a D in it. Of course, he won the Nobel Prize for discovering and sometimes you can do washout. Like 30% of adenomas have densities greater than 10. So some do have higher densities. Those are the ones that are more likely to be hyperfunctioning because they have less fat, they have more cortical tissue, are much likely to have either cortisol or aldosterone excess. But sometimes you can't differentiate, they may have to wash out. I don't find this to be very helpful often. It's certainly not necessary. If they have a low attenuation value, less than 10, you don't have to do this. But sometimes you have patients with benign lesions tend to have greater washout. This does not, however, distinguish pheochromocytomas. I've seen a lot of pheochromocytomas that have washout. So sometimes this is helpful. MRI can also be helpful in distinguishing whether if you have a strong suspicion of malignancy, whether it's cancer. Bilateral nodules are often seen. This is often a bilateral disease. This is much more likely to be metastatic disease. or adrenal insufficiency because there could be infiltrative lesions like lymphoma or other infiltrative processes. Probably if you have bilateral disease, some people think that adrenal hyperfunction is probably more common. There's some dispute about that, but I think it's probably true. So I talked a lot about hormone excess. Okay, what should you do? Who do you test? What to test? So who to test for hormone excess with adrenal nodules? You just have to test everybody. I mean, there's just not any exceptions to this rule. Everybody with adrenal nodules needs adrenal function testing, and it's not actually that difficult. And obviously, the things we're looking for are pheochromocytoma, primary aldo, cortisol excess, and rarely androgen. I mean, sex steroid excess is pretty unusual, and that can be just based on clinical grounds. So let's talk about pheo, because that's the one thing everybody seems to be all worried about. And again, if the Hounsfield unit is less than 10, you don't have to worry about pheo. You don't have to even they don't need to be tested. Obviously, catecholamic-producing adrenal medullary tumors, they can be malignant. They're often extrarenal. They're called perigangliomas, and they can be called part of multiple neoplasia syndrome. And if you look at the literature, it's about 3 to 5% of all adrenal nodules with Hounsfield units greater than 10. I think the 5% is a little high, 3% probably isn't that far off. So anybody with a Hounsfield unit greater than 10, particularly if they have hypertension in the adrenal nodule, this needs to be excluded. And of course, you all know the symptoms of hyperandrogenism, hypertension, headaches, and palpitations. But you know, in 2019 in America, I don't know how many pheochromocytomas are going to be diagnosed today in the United States, but I guarantee you that 98% of them were found because somebody had an adrenal nodule incidentally discovered, and then somebody had tested for pheo. I mean, I'm sure all of you spend your lives seeing hundreds and hundreds of patients, thousands of patients, and how many people come in with headaches, palpitations, and sweating, and you like, let's face it, it doesn't happen very often. So most pheos in the United States, not in the United States, all over the world, are now diagnosed as incidental adrenal nodules. So the test that we prefer, it's the simplest, is plasma-free metanephrin. It has great sensitivity and pretty decent specificity. There are some false positives, particularly plasma and noradepinephrine can be high in patients with this hypertension. And urine nephrins and catecholamines can also be secured. A true positive test with any of these studies is usually, these are way off they're off the limits. I mean, there's just no question that these patients have very elevated, very high levels. If they only slightly elevated, it's probably a false positive, particularly in somebody with hypertension. And there are many drugs that may interfere with this testing. They're too numerous to mention, but obviously you have to be cognizant of the fact that there are some drugs that may stimulate hyperandrogenism, many drugs. So just to give you an idea how important pheochromocytoma is, this was just one of my favorite studies. It was done by some oncologist at UCLA a number of years ago, and they had adrenal lesions suspected to be metastasis, 30 of them. And they did either surgery or biopsy of all the lesions. Well, 18 had malignancy, and they were, again, most metastatic disease to the adrenal retina, usually greater than 2 centimeters, usually greater than 3 centimeters. 8 had just adrenal adenomas that were benign, and 4 had pheochromocytomas out of these 30 patients. So, and one of them had an adrenal crisis after the biopsy that to find out it was malignant. So even in patients with malignancy, and when you see an adrenal nodule, this is going to be a metastatic lesion, you still have to rule out pheo. I mean, 4 out of 30 of these patients have pheochromocytomas. So it always needs to be considered in anybody with an adrenal nodule and a Hounsfield unit greater than 10. Primary hyperaldosteronism is very, very common. This is the most common cause of hypertension by far, and secondary cause of hypertension by a long shot. I mean, 5% of all people in the United States with hypertension have primary aldosteronism. If you have patients on 3 or more drugs, it's about 20%. So this is an extraordinarily common disorder, but rare cause of primary aldo because in patients with adrenal adenomas incidentally found. The reason for that is that most aldosterone producing adenomas are very small, like 8 or 9 millimeters, not 2 centimeters. Very unusual for an aldosterone producing adenoma to be 2 centimeters. If it is, that patient has profound hypertension, very high aldosterone, and profound hypokalemia. So, nonetheless, in anybody with hypertension and primary and incidental adrenal adenoma, this should be excluded, particularly if they have hypokalemia. But please understand that probably less than half of the patients with primary aldo ever have hypokalemia. So most patients don't have hypokalemia. And as I'm sure all of you know by now, this is an extraordinarily simple diagnosis to screen for. It's ambulatory, usually at best in the morning, often with a normal, but hopefully with a normal potassium and aldosterone and plasma being activity ratio. If it's greater than 30, you have a positive test, and confirmatory testing is needed. And they can do it with a patient on any medication with the exception of spironolactone or mineralocorticoid receptor antagonist. So this is just a simple test. First, it's best to do it in the morning, but we just do it whenever the patient shows up in the office, to be honest with you. But we're going to get an equivocal result. We often repeat it in the morning because aldosterone, like cortisol, has a viral rhythm. So this is extremely simple. Many of us talk with Bill Young, many of us believe that all patients with new onset of hypertension, certainly below at the age of 50, probably below the age of 60, should have screening for primary aldo because it is so common. In confirmatory testing, we currently just do 24-hour urines on a high salt intake. Sometimes this is necessary, sometimes not necessary. Or a saline suppression test. We don't do either one of these tests in the long run. This is often needed, but not always. But by the time if you have a high aldosterone and plasma activity ratio, those patients should really be referred to someone with expertise in making a diagnosis, a differential diagnosis of this condition. And the differential diagnosis always includes bilateral sampling, even in patients who have an obvious adenoma in their adrenal gland, because they usually don't. If they have a 2 centimeter nodule, it's probably not an aldosterone producing adenoma. So we do adrenal vein sampling, and we have Bill Rolling and Frater. He's probably without doubt, the best person in the state of Wisconsin. And we do a lot of these. And we can segregate primary aldo being a solitary adenoma, unilateral disease from bilateral disease. Obviously, unilateral disease we treat with surgery, as you'll see in a few minutes. Bilateral disease we treat with a mineralocorticoid receptor antagonist, such as spironolactone. So this is real simple aldo-renin ratio. It's not complicated. Probably the most common thing associated with incidental adrenal adenomas is cortisol excess. This is very, very common. In fact, this is Dr. Cushing who described this candidate of cortisol excess in 1932. His monograph describes the presence of small basophilic pituitary tumors as a cause of this syndrome, which is now bears his name. And of course, this is his first index case from 1910. The lady with obesity versus hypertension, non-amenorrhea. Now, this syndrome, as it described in the 20th century, it's a caricature of what it really is. So the term Cushing syndrome, I've tried to get abandoned from the literature, although I'm not been all that successful, but I'm making progress, because this is really not what it looks like in the 21st century. This is what it looks like now. So it's a whole different disorder than it was 25 years ago. So we know that many patients with high cortisol levels come from pituitary adenomas. This is called Cushing's disease, because that's what he described, causes adrenal hyperplasia and cortisol excess. We also know that ACTH tumors can come from other places, like the lung, pancreas, and a number of other spots. Ectopic ACTH. So these patients often have weight gain, facial fullness, plethora, tubercular fat, diabetes, osteoporosis, hypertension, neuropsych disorders, hypogonadism. We're all familiar with this syndrome. But, and if there's feedback, cortisol feeds back on ACTH production, but feedback, and the set point for feedback is just elevated, so we have to have a higher dose of steroids to suppress ACTH and cortisol. This was a very well done phenomenon. What is less well appreciated now is all these patients with adrenal nodule disease, either unilateral or bilateral, make a slight amount of cortisol excess, cause some decrease in ACTH. They're often incidentally discovered. The cortisol excess may not be sustained, but intermittent. They often have hypertension, hyperglycemia, diabetes, and metabolic syndrome. They have very high risk of osteoporosis, particularly vertebral compression fractures and lower extremity insufficiency fractures. And this is sometimes referred to as subclinical Cushing's. Now, if you've got obesity, hypertension, diabetes, and osteoporosis, and you think that's subclinical, that's going to be your definition. That's not my definition. And people say, well, their cortisol excess is so mild. So who cares? Well, mild cortisol excess for 30 years is a big deal. I mean, I just saw a patient yesterday who had adrenalectomy for his adrenal cortisol excess, post-op adrenal insufficiency, as you might expect. This guy had it 20 years ago. He had adrenal nodule. 20 years ago. Now he's got obesity, hypertension. I mean, what do you think, when you have mild cortisol excess for 20 years, what do you think happens? And I keep telling him, well, you think I'm kidding? I mean, let's do an experiment. Okay, let's do this experiment. Randomized, placebo-controlled trial. We have one group that takes prednisone, 3 milligrams, twice a day, and the other group takes placebo, and we study them after 15 years. Which group would you like to be in? I'm serious. So you see a 62-year-old person, because cortisol excess, even though it's mild, they have a 3.2 centimeter left adrenal nodule, and you go, well, but their cortisol active axis is slightly elevated. I mean, their urine cortisol is normal, their late night cycle report maybe just a little high. Who cares? I said, what do you mean? They have cortisol excess. They're 62 years old. Their life expectancy is, 20 more years, 30 more years. Why aren't you treating this? I still am, I'm absolutely mystified how people can just let this go by and say, okay, just treat the condition. Look, if I had cortisol excess, I want to go on, and I'll show you why that's important. And this is why I think the idea that this is called subclinical Cushing is ridiculous. Everything we do is subclinical. Even diabetes is subclinical. Most people, how often you see someone come in with polyuria, polydipsia, and we're occasionally, but usually they just come in and have a random fasting blood sugar of 165. Their A1C is 8.3%. They have no symptoms. Osteopenia, it's not symptomatic. Even hyperparathyroidism. And a lot of patients with low hypothyroidism and hyperthyroidism have no clinical symptoms. So, of course, thyroid nodules are obviously symptomatic. So almost everything we do in endocrinology is subclinical. So, cortisol with morbidity and mortality like a U-shaped curve. In fact, somebody at the meeting we did last week in Milwaukee really suggested all disorders are like this. If you have endocrine disorders, if you have too little, it's not good. If you have too much, it's not good either. And we do know that patients with bona fide overt Cushing syndrome have significant increase in morbidity and mortality. And the evidence is very persuasive now, is that patients with even low-grade cortisol excess have significant increases in morbidity and mortality, and particularly cardiovascular events, which I think I'm going to show you on one of the slides from that. So we don't call this, we call this mild cortisol excess. It's caused by nodular adrenal disease. It's ACTH independent. The adrenal nodules are producing cortisol autonomously without the help of the pituitary gland. The patients don't have florid symptoms, but they often have metabolic bone disease, high risk for low bone density, often have hypertension, sometimes very resistant and difficult to control. They have other features of metabolic syndrome, upper body obesity and diabetes, and they just have cortisol excess for a long time. Now, these patients, they used to be, back 20 or 30 years ago, they said, well, we'll follow these patients to see if they get overt Cushing syndrome. They don't. They don't. They just stay the same. Their biochemistry, their clinical status, oh yeah, maybe over time they gain a little weight. Their fasting blood sugar, instead of being 104, it goes up to 114, but they don't progress into overt Cushing's very often. Occasionally they do, but not very often. So here's a study where they just decided in Italy. And there were 3 studies published in 2014. They all showed exactly the same thing. And it was absolutely astonishing how close these studies were. And they're all about 200 patients. I'm not only going to show you one of them. This was a study from a group in Italy. And they did an retrospective single-center study of almost 200 patients with adrenal incidental. And they looked at their post-dexamethasone cortisol. Less than 1.8 was considered non-secreting, 1.8 to 5 was considered intermediate, and greater than 5 was considered subclinical Cushing's. And they followed them for 7, I think the follow-up, but it doesn't show it on here, 7.2 years. That was the mean follow-up, a long time. Now, I don't know how, the first thing I said, how could you go this long and never do anything with these patients? Because they didn't. They didn't treat them, they just followed them. Well, this is what happened. So the patients who had non-secreting lesions, this is a proportion with cardiovascular disease over time. A few, not many. But patients who had either the worsening phenotype over that time, that is, their cortisol levels got higher, or stable, look how much higher their cardiovascular event risk was. Went way up. So patients with mild cortisol excess have a very high incidence of having a stroke or heart attack. So so now that's very clear. What's not clear is whether if we take these out, does that reduce that risk? We don't know that for sure. There's no evidence that that's true, but I think until a randomized controlled trial is done, we're never going to know that, and that's never going to be done because we're never going to be able to get enough patients enrolled to do a study like that. So I think for the time being, I see a 62-year-old person who has has cortisol excess with an adrenal nodule. I mean, we take them out. Testing options. How do you test for this? Well, there's urine cortisol, late night salivary cortisol, DHEA, basal ACTH, and dexamethasone suppression, and we'll discuss briefly all these. This is a test you don't need to do, at least not for screening purposes. It's not a good test. It's very poor sensitivity. So most patients who have cortisol excess with an adrenal nodule have normal urine cortisol, so it's not a good place to start. We do this test if the other tests are abnormal, but we don't do this test as a screening test because its sensitivity is only about 30 to 60%. Very bad. Now, why is it so bad? Well, cortisol in the urine is about 0.1 to 0.3% of daily cortisol, not 0.1%. So if cortisol is metabolized in the urine to cortisone, and cortisone is not measured. When you do urinary-free cortisol, you measure cortisol, you don't measure cortisone. Cortisone is biologically inert, and now with these sophisticated tandem mass spec assays for cortisol and all sorts of other things, other steroids, it only measures cortisol. So it's like doing urine glucose to find diabetes. If you did urine glucose as a screening test for diabetes, and they had glucosuria, patients have diabetes. Probably have diabetes. I mean, you said somebody has glucosuria, they have diabetes. And some of you in this room are old enough, I'm one of them, to remember when that's actually what we did. I mean, we do a urinalysis, they have glucosuria, oh, you have diabetes. I don't think anyone would accept that now as it being a sensitive enough test to tell whether patients had significant impairment of glucose tolerance. So I think this test has been abandoned by us as a screening test. Now, late night salivary cortisol is a little better. It's not perfect in this setting. It's perfect in patients with ACTH screening tumors, but not so much in adrenal tumors. But it has, decent sensitivity and probably pretty good specificity. It's a little simpler to do than urine cortisol. Now, DHEAS is an adrenal androgen. Now, the reason this can be helpful is that patients who have ACTH-independent cortisol production, that is, they have autonomous cortisol production, on the adrenal that suppresses ACTH, ACTH levels are low. ACTH drives adrenal androgens, DHEA, so those levels should be low. So it has reasonably good sensitivity and specificity, simple to do, easy measurement, so we do it pretty routinely. Now, ACTH levels should always be done because if they're low, that suggests it's like TSH is low. You got low TSH, free T4 is high, or high normal. Patient has autonomous thyroid function. Hypothyroidism. Whether it's clinically important, that's a clinical decision, but they have so everybody is very familiar. The same thing happens with cortisol. if the adenoma of the adrenal gland is making too much cortisol, even a little bit too much over a long enough period of time, the ACTH levels fall below about 10 picograms per milliliter. So it's a very important test to secure in patients who have adrenal nodule. But clearly the best test that we have, and the test that should be done routinely in all patients with adrenal nodular disease, is a dexamethasone suppression test. And we give a milligram of dexamethasone at 11 o'clock, or though I've learned in Wisconsin that's pretty late for a lot of patients, so sometimes cheat, give it at 10 o'clock if they can't stay up till 11. And we measure our cortisol, ACTH, and dexamethasone level the next morning. Normal subjects are consistently less than 1.8, probably actually less than that, but that's the current criteria. Obviously, if they have ACTH-independent cortisol secretion, then the ACTH level is going to be low to start with. And if you give them dexamethasone, it's going to even be lower. And the dexamethasone level, we measure that because a lot of patients, some patients have rapid metabolism of dexamethasone, some people forget to take the dexamethasone. So we know whether they've done it. So we always get a dex level. And this has essentially 100% sensitivity, but there are some false positives. I don't have time to go over all the false positives, but there are some false positives. So the bottom line, you need a biochemical evaluation. Hounsfield units is greater than 10, you can concern about theo, plasma epinephrine, or if you prefer a 24-hour urine, we like the plasma epinephrine because we can just do that while in the clinic. Analysis on the linear ratio, pretty simple, and then an overnight dexamethasone suppression test. All you need to do. If the overnight dexamethasone suppression test is abnormal, then additional testing. ACTH, DHES, late night salivary cortisol if that's positive. So plasma-free meds, analysis on the linear ratio, and overnight dexamethasone suppression test. So how do we treat these? Well, theos, I think everyone would agree now, some exception. Almost all of them should be removed. They can be very capricious. You never know when one's going to go off, so I think it's important to do surgical resection in all these patients. We sometimes will do a cortical sparing theo removal in some patients with multiple bilateral theos, so the patients do not become adrenal insufficient and have adrenal insufficiency. Obviously, pre-op management is needed with alpha blockade. We don't use phenoxybenzamine anymore. We just use doxycycline or something like that, another alpha blocker. And sometimes even beta blocker is also needed if they have tachycardia. But hydration is very important. And obviously these need to be operated on in centers where they have the anesthesia support and endocrine support needed to provide good outcomes perioperatively. Primary aldo, if it's bilateral disease and we use a spironolactone or pyrrolidone for all bilateral disease, if it's unilateral disease, unless the patient does not want surgery for whatever reason, have comorbid conditions precluding it, and we recommend surgical removal. I mean, this improves the quality of their lives, a lot less hypertensive medication. Many patients have resolution of their hypertension. I mean, can you imagine being 43 years old, having a 4-year history of hypertension, you're on 3 drugs, they find, oh, you have primary aldo, we take out your left adrenal gland, you don't have hypertension anymore, you don't have hypoglycemia anymore. Wouldn't you want that? I mean, if you're 43 years old and you got hypertension, that's a pretty damn good outcome. So that's why we think everybody should be screened for this, particularly patients, whether they have adrenal nodules or not. And with ACTH independent cortisol excess, mild cortisol excess, adrenalectomy is always cured. I mean, this cures all the patients. How much benefit is a little bit less clear with mild disease. And I'll show you some data here. Now this is there's many studies. I'll show you kind of a meta-analysis of the studies that have been done. But this is Dr. Chiodini's from Milan. He was just talking in Milwaukee a few weeks ago to us, where he did a study back in 2010. It was in Journal of Clinical Endocrinology. 108 patients with adrenal incidental and 41 had subclinical cortisol excess. 25 of whom had surgery. 67 patients did not have subclinical hypercortisolism, but 30 of them had surgery for whatever reason, some other reason. And this is how they diagnose subclinical cortisol excess. And they found a large range of post-dex cortisols. Urine cortisols were all over the place. Plasma ACTH were all over the place. But this is what it shows. So if you look at the patients, 25 patients had adrenalectomy. 32% had a significant decrease in body weight. This I think is a 2-year follow-up. Blood pressure improved to 56%. Glucose improved to 48%. And the patients who did not have adrenalectomy, but had subclinical cortisol excess, untreated, worsening, 50% got worse, 38% went. So these people did not move on. And the patients who had untreated subclinical hypercortisolism, the patients who did not have untreated subclinical hypercortisolism, N equals 16, only 12.5% got better. So there wasn't much improvement. There was significant deterioration in that group of patients. Now, this is a retrospective analysis. I mean, it wasn't prospective. He also looked at metabolic bone disease in these patients. So if you look at this group of patients, a lot of them have vertebral compression fractures. These are basically cracked vertebral compression fractures. They found that in the patients who had subclinical hypercortisolism, who did not, but these are patients with adrenal adenomas, did not have cortical excess. They had the same prevalence of vertebral fractures as a control. In patients who have subclinical hypercortisolism, look at the percentage that has vertebral compression fractures. So most of these vertebral compression fractures have to be found in vertebral fracture assessments or direct imaging of the lumbar spine and thorax to find these. But the point is that cortisol excess increases the risk for vertebral compression fractures. And he has subsequently shown that if you do adrenalectomy in these patients, it markedly reduces that further compression fractures. Now, this is just a meta-analysis that Irina Vanka, who's a very bright young endocrinologist at Mayo, did when she was, she trained in Europe. I don't know if this was done when she was in Europe or not, but what she looked at is all the studies that look at adrenalectomy versus conservative management and for hypertension, diabetes, dyslipidemia, and obesity. And she looked at adrenalectomy versus conservative management, medical management, of course. And you can see in almost every case, particularly with hypertension, there's no question that blood pressure improves when you do adrenalectomy in these patients. Diabetes probably gets a little better. You can see it doesn't cross over. And I'm not so sure about lipids and obesity, and lipids are not quite so good. But hypertension clearly gets better in these patients. Now, it may not just be cortisol. I think these adenomas also make other steroids that may promote hypertension. So it may not just be the cortisol excess that we're removing. So what criteria should we use? Well, obviously what we do is we look at the patients. If they have metabolic bone disease, if they have a metabolic syndrome, cardiovascular events, we tend to be pretty aggressive about intervention. Obviously we want the cortisol low index to be greater than 1.8, low ACTH, relatively low DHEAS, and elevations of late night thyroid cortisol are ideal if they're present. And we look at the age of the patient, clinical manifestations, the biochemical profile, comorbidity, surgical risk, and of course the size and imaging. And so the bottom line is you sort of have to be a doctor. It's one of those things where you just still have to make clinical decisions based upon clinical information, good clinical information. Some cases, this is a 54-year-old, this is actually a patient from Fond du Lac, actually. This is the one I saw here at a, I don't remember who sent the center to me. 10-year history of hypertension on 3 meds. She's osteoporosis, on CA, parafasting glucose. She's not cushingoid. She did have a multinodular goiter. And normal electrolyte calcium, here's her 4.4 centimeter left adenoma with a low Hounsfield unit. So it's an adenoma, 4.4 centimeters. So it's a pretty good size, but it's got a low Hounsfield unit, so we can reassure it's benign. So what lab studies should you do? Well, we usually start with just these 3, and you already know a lot by just looking at these 3. I mean, cortisol is normal, but the ACTH is low, and the DHEAS is low. So you know this patient's got ACTH-independent cortisol production just from doing those 3 tests. Alpha-arena ratio is normal. And the DEX suppression test quite abnormal. Urine cortisol, as always, normal. Late night salivary cortisol were high. And she had a good outcome after surgery. Hypertension resolved. Now this shows you exactly why you need to send the patients to endocrinologist. This is a patient who I saw from Chicago. She had a left adrenal nodule since 2003. And this is the typical story. They've had this for a long time, and nobody's done anything about it. I see this everything. So she has weight gain, 140 pounds in 15 years. She's on 4 drugs for hypertension. She has prediabetes, low bone density, poor concentration. And she's had multiple endocrine evaluations since 2008. And they all had elevated urine cortisol down on the dexamethasone, so nobody's doing anything to figure out why that was going on. But we did late night salivary cortisols are high, urine cortisol is very high, post-dex cortisol 8.5. Here's the adenoma, low attenuation. But her post-dex ACTH is 25. It's not low. It's on the high side. So her ACTH is not suppressed. The DHA is not low. So this lady doesn't have autonomous cortisol production or ACTH independent. She has ACTH dependent cortisol excess with an adrenal nodule. And so then you have to do pituitary imaging, and she's got a pituitary adenoma. So pituitary ACTH-secreting tumor, and ectopic ones for that matter, can stimulate the adrenal glands and cause nodular adrenal disease. So adrenal nodule doesn't mean it's autonomous. So you always have to get that ACTH level to make sure it's not an ACTH-secreting tumor and that it's autonomous. So just to get back to the 20th century cortisol excess, I call this neoplastic hypercortisolism, not I think if this woman walked into your office, you would never think she had Cushing's syndrome. Because she doesn't have Cushing's syndrome, she has hypercortisolism. Fortunately, she worked for an Green Bay endocrinologist by Ferdinand Cases, who's a very good endocrinologist up in the Green Bay area. And she was 21 years old, and she had new onset of hypertension. And he said, well, maybe you're 21, you shouldn't be having hypertension. And he said, maybe you have Cushing's, and she did, and her ACH was high, she had pituitary Cushing's, and she had surgery at UW-Madison with a good outcome and a couple of young, very good outcome. She's done very well. She has had a recurrence, and now she's on clinical trials for new drugs for Cushing's. And this is a woman that had significant osteoporosis. She broke a pressure factor, she's only 51. And she had very severe hypertension, bilateral nodule. Everybody thought she had a field, but it turned out she had cortisol excess, low ACTH, abdominal duct suppression, high late night salivary cortisol, and resolution of her hypertension following renal surgery. And her bone disease, I think this guy never. There she is. And this is a woman with a 1.4 centimeter left adrenal nodule and hypertension, normal urine cortisol, elevated late night salivary cortisol, and abnormal ducts, and very low ACTH. And I didn't used to think that a 1.4 centimeter, I used to tell, when I gave this talk, that if it's less than 2 centimeters, you don't have to worry about it. I was wrong. Okay. If it's 1.4 centimeters, particularly if its Hounsfield unit is not low, she had a Hounsfield unit, I think, of 40 or 50. So it doesn't have much fat in it. So small adrenal nodules that have a indeterminate Hounsfield unit, that greater than 10, still have a very high likelihood of having cortisol or aldosterone excess. So, and she had resolution of hypertension following adrenal. So, just in summary, approximately 20 to 40% of the incidentally discovered adrenal nodules are associated with steroid acquired protein excess. Imaging characteristics, size, mortality, Hounsfield units, as well as the age of the patient are important factors in clinical decision making. An adrenal biopsy is only indicated after the field has been excluded in patients with biological enlargement or adrenal insufficiency, or in patients with a known malignancy, whether it's metastatic disease will change the therapeutic concept. So, adrenal biopsies probably are just rarely done. Probably in the last 5 years, one patient, and I see 50 of these a year, so not very much. All adrenal nodules greater than 1 centimeter should have an endocrine evaluation regardless of the clinical phenotype. And unfortunately, this does not happen, even in our center, and we are working hard to change this. Radiology reporting of incidental adrenal nodules should reflect this imperative, and it does not. And I'm sorry that they also, they don't believe me, I don't know if they don't believe me or what, but they do not say, they just say, don't worry about it. The patient has a 2.4 centimeter nodule, look the same 2003 as it does now. Yeah, it looks the same.
Yeah.
But if the patient has cortisol aldosterone excess, the patient might not look the same. Thank you very much. I think we have time for questions. Thank you very much.